Some of you have asked me to talk about joint examination, so these remarks are by way of an introduction to joint examination to give some ideas, some thoughts on how one might approach this particular aspect of assessing a patient with arthritis. There are two parts. One is fairly simple, the method we use to examine joints. But before we go to that, I want to give you some background considerations and ideas that might be useful to you when approaching a patient with joint disease. First of all, the examination of the joints must be informed by history. A large proportion of your information will come from the history. The patient therefore needs to be questioned fairly thoroughly, whatever their musculoskeletal problem. And that history will give you an idea about the siting of the problems, which joints are involved, but also the pattern of that involvement. It'll allow you to focus your joint examination on those particular problematic areas. It should also give you some idea of the process involved, whether it be that inflammatory or mechanical, and to some extent what sort of structure is involved. Now, consider the joint not as an amorphous mass, but as a series of tissues in a localized area performing a particular function. So, what structures might be involved? Well, inside or on the outside of the joint, you've got the ligament and capsules. Inside the capsule, one has synovium, bone, cartilage. And then running across the joint, you have tendon sheath with muscle. And then within the joint, you have fluid. And one also has to always think about the alignment of the joint. We start in this model of two knees. As an example, we see that the joint is composed of the two opposing bones. There is cartilage lining both bones, giving it a low friction surface. The synovium is on the outside, away from the articulating surface, and reflected onto the capsule. Now, if we add in some of the connective tissues, that is, they're the ligaments around the joint, and also the capsule, and they're of similar material, but these are enclosed. Then within that is the synovium and the synovial fluid. Outside those ligaments, which constrain the joint to move in certain designed directions and not to move in other abnormal directions. So outside the capsule and the ligaments, one has the muscles and tendons. And the muscle always ends in a tendon, be that long or short, and the muscles and tendon cross the joint in order to move the joint. Some of those tendons have contained synovial sheaths that can be the source of disease. So when one looks at a joint, one must think of those different layers. So the analogy in looking at a joint like this in its layers is, you don't approach abdominal examination or examination of the chest without having some image of the underlying structure, be that where the liver is, where the spleen is, the kidneys, what you're palpating or what should be under the area you're palpating or under the area you're auscultating. Well, similarly with the joints, one has to be cognizant of the various tissues and structures underneath the skin and moving or stabilizing that particular structure. So much for background and for how one might approach thinking about the joint. Then there's the method, and there's quite a simple method. It's look, feel, move. So one looks at the joint. Now, one of the advantages of most peripheral joints is that you have a corresponding joint on the other side, and for most of you, you will have a reference normal joint that one can refer to when looking for range of movement, etc. So you look for symmetry, symmetry with the joint on the corresponding side, alignment of the joint, and one can refer for many of these things to your own or to the joint on the other side. To move the joint, here it warrants some sort of thinking about. There is passive movement, active movement, resisted movement. So passive movement, you're looking at or you're examining structures on the joint lines, such as the synovium, the cartilage, bone, and the joint cavity. And so if there are abnormalities within that structure, one will generally find problems on movement, both passive and active. Whereas patients who have primarily tendon, muscle problems, and sometimes ligament problems, their passive movements in the normal directions will be normal and unimpeded. Active movements may be painful or tender. Resisted movement is useful when we're looking and examining whether the lesion is primarily of a muscle or a particular tendon, and movement of the joint using that particular muscle or tendon against resistance will often evoke the symptom or pain in most cases. And then one can look for abnormal movement out of line with what one would expect, and that may be because of ligamentous instability, and that could be rupture, like chronic rupture as in rheumatoid arthritis. So they're the sort of considerations. Now, not every patient be as simple to define as I have represented it, but it does give you at least a structure on which to work. And then feel the joint. And one should always feel the joint for increased local heat and for tension. And in the majority of cases, one is looking at peripheral joints. One is not going to find increased local heat around a hip or a deep joint like that, or shoulder less commonly. So one has the opportunity to compare that symptomatic joint with its asymptomatic counterpart, or compare the temperature over the joint with the temperature over a local muscle mass to see if there is in fact a difference. So I would hope that these thoughts would help you with nearly any joint. Now, with individual joints, there are particular issues that will arise. You need to talk to the patient. One needs to tell the patient what you're doing, why you're doing it, so they understand and they can cooperate. With regards to individual joints, that isn't the subject of this particular presentation. So thank you for your attention.